and which takes us to the point, if you're on a diuretic, you probably don't want to be taking that at night, right? We take our diuretic in the morning, so we don't have to get up and pee in the middle of the night, which disrupts our sleep. So what are some different options to help with sleep? So we talked about some non-pharmacological management of sleep, but what are some medications that are helpful? So some of the major ones that are first lines that we think of, how many heard of Restorol or temazepam is the generic name? Okay, that's a benzodiazepine that's indicated for sleep. And then we have the main ones that you think of, Lunesta, Ambien, and Sonata. You guys have all heard of those? Okay. So Lunesta is the longest acting. So if you're having problems with falling asleep and staying asleep, that's probably one that's going to be the best. And then there's Ambien comes in a long-acting version as well. So if the regular Ambien is not working long enough, there is a longer-acting one that you can use. Yes.
Do you have an estimate as to how much insomnia can be treated non-pharmacologically?
Off the top of my head, no, but I think we can. That's definitely a first try that we can do. So,
is it often the case that you try it and you're like, oh no, we don't need medication?
I usually, to be honest, I usually give them medications and give them the non-pharmacologic. I don't do just non-pharmacologic and come back because I'm on a inpatient acute care psych unit. But I think if it's mild insomnia, it should be okay. But if they need the medications, then we can give it to them. So yeah, I don't have an exact number of how effective non-pharmacological is, but it is a first line option to consider. Yes.
What about some of the side effects, and what would you say is the minimum amount of sleep that is fine?
That's an excellent question. So I get that from my patients, and I say, one of the key indicators to take away is when you wake up, do you feel rested? Right? And I see you smiling at me. You're like, what does that even mean? So I can sleep 12 hours sometimes and I don't feel rested, right? Versus there's some nights I sleep 7 hours and I feel really good when I wake up.
So is the first one probably bad? Because I'm speaking for myself and my sister right now. I have problems sleeping lately, probably stress-induced part of it and work-related. But she also sleeps sometimes 10 hours a night or more. I feel like that's kind of bad.
Yeah.
It depends on the person. I sleep 9-10. Bill Litton slept 9-10.
Yeah.
So each person's different.
Yeah. So that's what I was saying. It's
And there's a whole other thing. It's Sundal.
Yeah, sometimes the antidepressants cause people to sleep a lot.
Yeah. Or sometimes I have patients who say they have a next morning hangover effect from Seroquel, where it's been used to help them sleep, but then in the morning it's hard to wake up and they feel
What do you do with that? Where does melatonin fit?
Oh, I was just gonna go into it right now.
Before you go into it.
Yeah, what do we do with that hangover effect? So Seroquel does come in, so that's with the immediate release I've seen it. So one option is extended release, something that could be an option for them. Or can they take it maybe just a little bit earlier and see if that would help them? Or are they getting used to it? Sometimes you as your body gets used to it, some of these symptoms can improve. So it's just something for them to talk to the doctor and see what is the best. And melatonin, we are going into in a minute.
I took trazodone for the first time last night. Is there any concern about that being hypothermic?
No, that's an antidepressant. It's not a controlled substance. So we're good.
What's an ibuprofen PM?
Ibuprofen PM probably has some kind of Benadryl or Benadryl-like medication in it.
Which can cause Alzheimer's, they found out.
Yes.
Research.
So highly anticholinergic medications can actually possibly increase risk for Alzheimer's. Do we really know that there's some preliminary studies that show it's possible? So that's why we try to limit. So medications like Benadryl or Paxil's highly anticholinergic. So there's a couple that are a few questions about those. But I don't want to confuse you. So trazodone is an antidepressant, but we don't use it for depression. We use it at lower doses for sleep. So, but it's not a controlled substance. So
I used to take the Benadryl also.
Okay.
This is new to me.
So Benadryl, fun fact, if you take Benadryl every night, How many have tried to take Benadryl every night? And what happened after like maybe 5 nights or a week? It stops working.
It's
Yeah.
what?
It stops working. Benadryl, if you take it every night, stops working for sleep. So it's like more of like a very short-term option. So trazodone is something that you don't get, like it works as you continue it. So that's why it's like when people take Benadryl every night for sleep, we usually say it's like the doctor's probably recommending it here or there. It's not a long-term solution. So,
I've tried Ambien one time on an airplane when I was in China. I didn't sleep for a second. I slept for 20 minutes.
so it wasn't very long acting for you. So maybe like a Lunesta is something that's longer acting, might be an option to consider. Sonata is actually the shortest acting. It's usually like if you're somebody who maybe is a shift worker and you just need something to help you fall asleep but don't want to stay asleep, it's an option. It's very short acting. And then Melatonin is a prescription version of melatonin. Melatonin?
Why not just take Melatonin?
Exactly. So, but I would talk to your doctor.
Gabapentin.
Yes.
Some people are using that to help them go to sleep.
It could be sedating, but I haven't seen people using it for sleep. It's something that can help with pain, in some cases anxiety, but I haven't seen it used
They're
for sleep.
anxious and that's why they can't sleep.
Possibly, but it can be sedating, so yes.
I just had a question. Do you know if any of the Sonata, I know Ambien is not approved for people over 65, insurance won't cover it. Are any of the Sonata or Lunesta covered?
They're all in that same family,
That's
so
what
I
thought.
would say they all probably have risk as you're older because they can maybe increase your risk for falls and those kind of things. So that's why when I remember it was maybe 4 years ago when I was at Kaiser, we were looking at options. Some of the options we were looking at alternatives were the antidepressants used for sleep, but those may not be effective. Those are more effective like if you have concurrent depression and so forth. But sometimes they do use those. So we talked about trazodone and Remeron. Those are the antidepressants that we use that could help with sleep. Okay, so we already talked about which over-the-counter medications or herbals can help with sleep. So you guys are already anticipating everything I'm going to ask today. This is fantastic. Okay, other if time. So how are you doing on time?
You're done, past.
Well, we can keep going for a little bit.
It's 8:35.
No.
It's time for questions. Almost
Okay,
8:40.
let's take questions. I saw a hand back there first.
What about Valerian?
I want to say, if I remember correctly off the top of my head, I haven't looked at that in a long time, but valerian and some of the other ones for anxiety, I think they had benzo or sleep. They had benzo-like properties. I wouldn't use that. So, if I'm not mistaken from looking at it. Okay.
Well, what about genetic testing to see what antidepressant you metabolize?
Excellent question. So I didn't go into genetic testing, and in the last decade, I've had maybe a handful of patients that did genetic testing. Genetic testing was more like if you've tried all these different medications and nothing's working, and you're like, why? Genetic testing might give us an idea about how your body breaks down the medications, for example, because they go through things. Some of them go through things called enzymes that we call them cytochrome P450 enzymes. So they'll tell us like if you aren't as good at breaking down one, or if you're so. It might guide us in what options to consider, but some patients find it not helpful, and it can cost a lot of money. So that's up to you if to see does your insurance cover it, and if they don't, what is the cost? Because it could be quite costly in some cases.
Would that be 23andMe?
No. Oh, you okay?
Yep. Nothing to see here.
Can you give us an example of what information it would like elicit?
Okay, so for example, some of the medications can be broken down by, let's say, CYP3A4. I'm getting very technical here, or 2D6, and it'll tell us, okay, do you not have enough of those to break them down, or what's going on? So that, for example, we can look at it'll tell you like avoid these antidepressants, for example, that go through that, and these are better options
Alright.
based on your genetics.
Wouldn't that theoretically save you some time, because then you can actually find the right prescription?
I've had patients who've tried the alternatives they suggested and they weren't helpful. They didn't work. So I'm just saying it could be an option to consider, but there's no guarantee that it's going to give you what you're looking for, and it could be costly. So I would look at the cost benefit of it. Like how much does the insurance cover it, and how much would it cost? Because I've gotten very different things from patients. Some saying it costs very little, some saying it costs a lot for them.
Does
Yeah.
the accuracy of that depend on the size of the gene pool?
I don't know. I haven't gone all the way there with it, but I think they're looking at your, like they do swabs and they look at your specific thing. So I don't think it's based on that. I think it's accurate. It's just,
But that can also
is the information helpful?
based off their like body chemistry during a certain time, like if they're super malnutrition, couldn't their genetics be different at that time?
So
Like if a person doesn't eat right, they smoke a lot and all that stuff, couldn't their genetics be worse at that time versus like if they were 10 years ago? And that would systematically maybe not be able to
but I don't know if that affects your cytochrome P450 system. But smoking, I didn't mention this before. Smoking, the hydrocarbons in cigarette smoke induce, what it means is it increases the breakdown of cytochrome 1A2. So, for example, if you smoke, if you smoke and you are on Zyprexa or Clozaril, it lowers the levels. So if all of a sudden you stop smoking, those levels can go up. So it's really important to let your doctor know that you quit smoking if you're on a medication, so they can just be aware if it's something where it's going to affect the medication levels too.
Is that true of vaping also? Do you know?
With which one?
Vaping. People who vape.
I have not heard of it with vaping. I know it's specifically the hydrocarbons in the cigarette smoke. Yeah.
This is more of a general question, but some people end up on 4 or 5 medications at one time. So how does that happen? You start with one thing and then you see a symptom or a side effect and you try and treat that, and then so how many would you say? Is there a maximum amount? Is there a yardstick, or do some people have 8 medication?
It's very specific to the person, but I've seen very long lists of people on very long list of psychiatric medications. So it all depends on how many conditions we're treating. And then sometimes, unfortunately, we find the right medication, but we have side effects, right? And because that medication works so well, sometimes it's like the benefits of treating the side effects outweigh of trying something else. So we do end up sometimes needing to add on medications. For example, if you're on Haldol or one of these other antipsychotics like Risperdal, if you're on higher doses, maybe the doctor might add on a Cogentin or a Benadryl to help prevent movement side effects. So we do unfortunately sometimes do need to add on additional medications. Sometimes it could be they were trying to switch between 2 medications. All of a sudden you're doing so well, they're like, let's not change anything, right? So things can change over time. For example, when you're in the hospital, they might be a little bit more aggressive. Maybe a little bit time later, you can talk to the doctor and work with them and say, do I need to be on all of these? Is there something that we can look at and slowly work with? So it's a lot of different factors that go into why we end up with a list of medications. And sometimes it could be, you think you're supposed to be in it, maybe not. So it's always good to check with the doctor too. Always have like an active list of this is what I'm taking, is this correct? Is this what I should be on? Yeah.
Could you answer your question here that you had any quick acting medications to help with anxiety that are not controlled?
Yes, thank you for bringing that up. So this is like one of the most common things I get from my patients, because a lot of my patients are dual diagnosis. So meaning they have a psychiatric condition, but also in a history of let's say alcohol use disorder or opioid use disorder, and they don't want to put themselves at risk, right? Because any medications you give them that could be habit forming can put them at risk for relapse. So one of the medications, believe it or not, is hydroxyzine. How many of you have heard of hydroxyzine?
Yeah. What's else called?
It's Atarax or Visceral. It comes in 2 different names. So it could work within 20 minutes, 30 minutes, and it's something you can take as needed. So the doctor prescribes it. So talk to them and see if that's something that's right for you or not.
Can you spell that on the name?
It's hydroxyzine. I can write it.
And the other names of it?
Is Atarax and Visceral. It's just those 2 come in just different dosage forms. So depending on if they want you on a higher dosage or lower dosage.
So non-habit forming?
It's not habit forming, and it could help with anxiety. I had one patient recently in my med ed groups who stood up in front of everybody, was like, "You need to listen to Dr. Alipour because I've been listening in her groups, and the one medication that she brought up that's changed my life." And I was like, "What medication was that?" And then he's like, "Hydroxyzine." I'm like, "Hydroxyzine? That's the life-changing medication," but for him it was. So everybody's different with what medication works for you. So and each person responds differently. I think here, and then we'll go there and then there. Okay.
Anti-craving medication?
Yes, for which alcohol, opioids?
Alcohol.
Okay, so we have actually 2 main ones. I don't know if you've heard of any of them. We have Camprol. So Camprol, it kind of goes in and acts like a fake alcohol, but it doesn't prevent seizures or anything. But it kind of takes like the edge off of things. It helps with cravings and relapse, but it's dosed multiple times a day. So that's kind of like the downside of that one. And that one might give you, I believe, some stomach things with that one. The naltrexone is the most interesting one because naltrexone comes in a pill called Revia, and it also comes in a long-acting injectable called Vivitrol. The Vivitrol is given once a month. And not only does it help you with cravings for alcohol, but it can help with cravings for opioids. So the way that it works is it goes and it binds to the mu opioid receptor, the one that opioids would bind to, and it blocks it. Now, that's what naltrexone does. So, for example, it's thought that some of the reinforcing effects of alcohol are it goes there and it increases dopamine, which is a pleasure reward neurotransmitter, and that causes the reinforcement of alcohol. Because it doesn't allow that to happen, my patients tell me when they're on naltrexone that they get all the bad effects from the alcohol without experiencing any of the good things. They're like, so what's the point? That's kind of how they feel about naltrexone. And then there's the last one that I like to call the punishment pill. I don't know if you guys have heard of that one. No. Buprenorphine maybe in some ways can be anti-abuse. And it's literally in the name, the punishment pill. So what it does is like, it goes and it permanently binds to and destroys one of the enzymes that breaks down alcohol. So basically, if you drink when you're on it, and it can last to 2 weeks, it takes 2 weeks to regenerate that enzyme after you stop it, is you can't break down the alcohol, so you can get very sick, like deadly sick on anti-abuse. So you got to be very motivated to abstain if you're going to be on anti-abuse. So it's not a first line because of those reasons. But Camprol and naltrexone are. My doctors start a lot of patients on naltrexone.
What's the difference between Camprol and naltrexone?
It's their mechanism is completely different, yeah. And then the Camprol is multiple times a day. And then I believe Camprol is renal. And naltrexone is more liver. Like if you have really high liver enzymes, it's not a good option.
So sleep aids often increase sleep quality. Are there any sleep aids that stand out as better sleep quality?
I heard someone say melatonin. It's like you're saying because it's natural, because that's what's naturally released.
It's also a neuroprotectant.
Can you take
Yeah.
as much as you want?
No. No.
Why not?
If you go too high a doses, I've had some psychiatrists say where it can actually have depressant effects. I don't know about that. That's what one of the psychiatrists told me. So
I'd like 10 milligram, like strong ones. I don't really feel like.
usually I see it between 3 and 9. I wouldn't go above 9.
Really?
But I would talk to your doctor if you've been taking it and that's how you've been taking it.
I'm not saying, I mean, I've tried like 10 before, but it's like, it helps me sleep a little bit. I feel like that side effects, it's like I can sleep.
Okay, but it worked for you, it sounds like.
I think it becomes less.
We have one more hand in the back, should I stop? Or two more, actually, she was before, and then we'll go. Go ahead.
So, can you explain to me how Topamax works for bipolar disorder because I looked it up and it's really supposed to be, a primary use is for cluster headaches, but.
Yeah, it's not a good mood stabilizer. It's not a good mood stabilizer. One of the reasons I've had patients actually want to be on that is because they don't get the weight gain.
Right.
Yeah.
Right.
So, yeah. Is that why? I don't know. So that's one of the reasons I've had patients, like that one, but.
That's the reason why she doesn't want to do it, because, or that's why she suggested, because all she talked about is weight gain.
So
She has a horrible diet of sugar and soda and bread.
So if that's a concern, there's other medications, like probably then she wants to avoid lithium and Depakote because she probably thinks like she sees on the labels that they say they can cause weight gain. There's other antipsychotics that could be used as mood stabilizers that are more weight neutral. So they do come at, like Abilify comes in a long-acting injectable. So I would still go back to the long-acting injectable and talk to her about that. Okay.
What about things like ADHD? Because I've actually been referred by psychiatrists.
Oh, they're recommending it. Okay. Okay. I personally, because they're not regulated, I usually stick with the prescriptions. And usually they get sent to me when they're on a bunch of herbals, and they're like, look at their list and try to figure it out and see what's going on. Are they causing side effects? So I get it on the other end. So I'm not usually the one recommending those. There are some evidence with those, but I personally don't usually like go on and recommend them. If the doctor's recommending them, then I would go with
Well, that's also kind of the other question. What's your opinion on all of the advertising for medications? Are they causing challenges on your end? Because people come in saying, well, I saw this commercial for Tuda, and I can take it.
How do you make your?
At least they're making awareness, I like it. I
So,
like just making awareness.
they're actually, if they advertise, they're actually required by law to give all those side effects. They don't do it because they would want you to take it, right? So they would try to, and usually the ones that you see on TV are all the ones that are brand name because they make a lot of money by selling the drug versus the ones that are generic, like Cymbalta, you don't even see commercials for it anymore. I personally don't like them advertising on there. I think that they should be hearing it from the doctor. There were some new ones where they had an indication, and literally had a script of like, here's the things to tell your doctor to get this medication, and I'm like,
Isn't that backwards?
yeah. So it was like Vyvanse for like binge eating disorder or something. I'm like, this is bad. You're like coaching somebody how to get a stimulant to. So yeah, they try.
I just want to not interrupt any further questions that you want to do, but I want to take a chance for us all to just thank Dr. Alex. And for we'll see you all at the next meeting, and if you still want to stay and ask questions, go ahead, but we're just going to start picking up some stuff. Okay, let's go. Thank you.
Oh wow, it's already 9.
Yeah.
Quick question, what about someone not on medication, like